Welcome and hello, everyone. Thanks for joining us today for the first of the ACTA2 webinar series, focusing on ACTA2 associated genetic aortic disease, an overview and the current understanding from research. This webinar is jointly hosted by the Genetic Aortic Disorders Association Canada, also known as GADA, and the John Ritter Foundation for Aortic Health. I'm Chrisanne Campos, the Scientific Director with GADA, and with me today is Ellen Hostetler, the Chief Science Officer for the John Ritter Foundation. Before I hand this over to Ellen and our invited speaker, I'd like to say a few words about GADA. GADA has been, it's a registered patient advocacy organization in Canada, been in existence for the last 36 years. We extend our support to individuals living with genetic aortic disorders through our support for research and events that promote education and awareness. GADA's primary research support goes towards funding the patient registries of the Montalcino Aortic Consortium, also known as MAC-AORTA or MAC. MAC is an international collaboration of clinicians driving precision medicine for genetic aortic diseases using the patient registries for research studies. MAC has published many papers on different genes involved in genetic aortic diseases, including ACTA2. And some of the findings of MAC research were even considered in the new guidelines for aortic disease management that were published by the American Heart Association and the American College of Cardiology. We are really happy to have with us Dr. Dianna Milewicz, the Executive Chair of MAC, who is leading the MAC registry in Houston, to talk to us more about her research on ACTA2. Dr. Milewicz has also been on GADA's professional advisory board for many years, providing her invaluable expertise for the organization. Thank you very much, Dr. Milewicz. And I'd just like to make a quick announcement. GADA Canada is a sponsor and a partner for the Hereditary Aortic Disorders Symposium, which is scheduled to be held in Halifax in Nova Scotia, Canada this year on June 23rd and 24th. The first day of the conference is an education day for medical professionals, and the second day is dedicated for patients and families. This is a great opportunity not only to hear updates on hereditary aortic disorders, but also to have a chance to meet with leading experts in the field, including Dr. Milewicz, who will be there at the symposium, and a chance to connect with other families. If interested in attending this symposium, please stay tuned to the GADA website and GADA social media for more details on registration. I now hand this over to Ellen and our invited speaker. Thank you.
Hello, we are so excited to be here with you today. My name is Ellen Hostetler, and I'm the Chief Science Officer for the John Ritter Foundation for Aortic Health. In case some of you joining us today aren't familiar with our foundation, we were established in 2003 by Amy Yazbek after the sudden and tragic death of her husband, the actor John Ritter, from an aortic dissection. And I believe that actually back in 2003 is when Amy first met Dr. Milewicz. And since then, they've had a very close and fruitful working relationship. And Dr. Milewicz is the longtime chair of our professional advisory board, and she also serves on our board of directors, which we are very grateful for her time and expertise. As an organization, we host virtual and in-person patient events and also provide resources for patients and families with ACTA2 related aortic disease, other genetic aortic disease, but also patients and families who have thoracic aortic aneurysms and dissections, but do not have a genetic diagnosis. So we have quite a large tent, and everyone is welcome to it, both in the US, but also worldwide. And I've just listed below a few of the research projects that we're currently funding, including our ACTA2 specific research study, just to give you an idea of the areas that we work in. I'll move on to our disclaimer, and I'll only put this up for a minute, but please feel free to contact us either at GADA or the John Ritter Foundation if you have any questions about this. In short, the information being presented today should not replace necessary consultations with qualified healthcare professionals. If you do need advice about how to find one of those in your areas, please feel free to reach out to us either at GADA or the JRF. This is just a quick housekeeping slide, and we are using Zoom, which I think people are becoming more and more comfortable with these days. But just as a reminder, there's a Q&A and a chat area, so please ask questions and feel free to chat with others, but always keep those respectful. We will have a time for question and answer at the end of the session today. And of course, this event is being recorded, so it will be available on both the John Ritter Foundation and GADA's YouTube pages later. With that, I will move to just go ahead and present or introduce our presenter today, Dr. Milewicz, because I know she's the reason that we're all here and we're excited to hear from her. Dr. Milewicz is the President George H.W. Bush Chair of Cardiovascular Medicine and the Director of the Division of Medical Genetics at UT Health Science Center in Houston, Texas. She is the Executive Chair of the Multitudo Aorta Consortium, and we already heard how she works closely with both GADA and the JRF. The reason, however, that we are especially thrilled to have her speaking with us in our community is, of course, Dr. Milewicz and her team were the group that first identified ACTA2 as a cause of thoracic aortic aneurysms and dissections all the way back in 2007. So we are very lucky to have one of the world's experts, or the world's expert in ACTA2 here with us today. And with that, I will turn it over to her and check back in with you all when we're ready for the Q&A.
Great. Thank you. Thank you for that nice introduction. Where did it go? Your slides went away just a second. And it's a real honor to be asked to talk to all the people involved and who have questions about ACTA2. So I'm going to start by just probably about a 10-20 minute presentation on ACTA2, and then just open it up to answering questions. I just want to give you an update on what we understand about the clinical disease associated with changes in the ACTA2 gene, and then where we are in terms of treating those changes. And there's been a lot of exciting updates since we first found the ACTA2 mutations, and I could talk for hours about the science of those updates, but it would put everybody to sleep except for me, because I'm a real nerd. I like the science. But what we're doing in terms of studying the ACTA2 mutations is with the goal of having better treatments to prevent the problems with the arteries associated with changes in ACTA2. So I'm going to go ahead and share my slides, and we can go ahead and get started. Okay, can everybody see that okay? Good. Unfortunately, I can't see all the comments as I go through now. For many years, I've been working on this condition. Here's called thoracic aortic disease. Here's the normal aorta. The heart sits right here. The aorta comes up, goes up like a candy cane, and then goes down. And this is the biggest artery in the body, and it provides blood to the entire body. So as it comes out, you can see these branches go out to the arms and up to the brain, and then it goes on down to feed the rest of the body. And so this is a really critical structure in terms of making sure that blood gets throughout the body. And an aneurysm is an enlargement of any part of the arterial system. An aortic aneurysm involves the aorta specifically, and thoracic aortic aneurysms, the type that we're interested in, are those that happen just above the heart and involve that very first part of the aorta. And an aneurysm is just a ballooning up or enlargement of the aorta, and it occurs because there's changes in the wall that make the wall weak. Now, nobody dies of an aneurysm. You can sit there for years and years with an aneurysm. There tends to be absolutely no symptoms. And like I said, it doesn't cause any problems until it becomes so big that it becomes unstable. And then what typically happens with these aneurysms involving the first part of the aorta is that there's a tear in the wall of the inner lining of the aorta. The blood goes into the wall and then starts flowing in the wall through the layers of the wall instead of inside the artery. And that's called an acute aortic dissection. And because this can suddenly burst completely, or even dissect all the way down and start cutting off arteries to the brain and arteries, even to those arteries down here that feed blood back to the heart muscle, it can cause a lot of life-threatening complications. And our current data says, data say that when an acute aortic dissection like this occurs, that a large number of the people never make it to the hospital because they have sudden death. And the people that do make it to the hospital, it's a surgical emergency. They have to go to surgery, and there's further deaths and disability associated with that surgery. So, but if we can identify people who have an aneurysm, we can go in and repair this aneurysm and prevent the dissections, prevent all of the deaths due to dissections. And that's really the goal of my research. It's the goal of the John Ritter Foundation. It's the goal of GADA Canada. All of us are here because we want to figure out who's at risk for these aneurysms. We want to know how to manage the aneurysms in the best possible way in every single person, and to go in and repair it and prevent all the premature deaths due to dissections. And so my work has really focused on what are the changes in our DNA that predispose to this disease. And we had known for a long time that if you look at a family, that these aneurysms leading to aortic dissections can run in families. And when they run in families, they typically get passed down from one generation to the next. And that's called autosomal dominant inheritance. And it means that in the people's genetic material, they have one normal gene and one altered gene. And it's that altered gene that's causing the disease. And when they go to have their children, they can pass on the normal gene and get a normal gene from the partner, and the child would not have the disease. But if they pass on the altered gene and then get a normal gene from the partner, then the child has the condition. So most of the genes predisposing to thoracic aneurysms and acute aortic dissections are inherited in this autosomal dominant manner, which means that a person has a 50-50 chance of passing it on to each child they have. And if the child doesn't get it, they cannot pass it on further. If they do get the alteration, they have a 50-50 chance of passing it on down to the next generation. And that's shown here. This is a pedigree where the men are in squares, not surprising, and the women are in circles. This line between two symbols means they're married, and these are all the offspring. And you can trace it on down. So, and then the black are the people that have thoracic aortic disease. So in this arm, it got passed down to an individual, got passed on down to the children. You can see sometimes there are people where it goes through them, but they are not blackened in as having the disease. And that's called decreased penetrance. I mean, somebody can get the gene, pass it on to their children, and their children have the disease, but they themselves do not have it. And that tends to occur in our families, and it tends to occur primarily in women, but not exclusively in women. And I'll show you a case with an ACTA2 mutation where it occurs in men also. So we've been really going after the genes that cause disease in families, but we can use this information already clinically, as we did in John Ritter's family. When he had his dissection, We went through and imaged everybody in the family for aneurysms. Turned out his brother, Tommy, did have an aneurysm. It was repaired, and Tommy's still with us today. So even without knowing the genes, just through imaging for those asymptomatic aneurysms, we can change the outcome in a family where it has it inherited in this autosomal dominant manner. But we want to find the genes because we could then go through and very specifically identify who's at risk and who isn't, and who needs to be imaged for aneurysms and who we don't need to worry about. But also, we want to understand when somebody has a particular gene alteration, when do we need to start medications to slow the growth of the aneurysm? And most importantly, when do we have to go in and repair the aneurysm to prevent the dissections? And with some genes, we can just watch the aorta grow just a little bit before we need to go in and repair it. Whereas with other genes, we can watch the aorta grow to 2 times its original size before we have to go in and repair it. So it really can make a lot of difference in terms of understanding the gene can make a lot of difference in terms of when we send people to surgery, and also how much imaging we do on an individual, and at what age we start that imaging, and I'll show you in a minute. So we've been working on trying to identify all the genes that predispose to this disease. This is our current list of genes. So we found a lot of genes, but we can only explain the disease in about 40% of the families in our research study. So we still have another 60 to 80 genes to identify based on our estimations. But my lab has been fortunate in identifying the majority of the genes here. And what I'm going to talk about today is specifically this ACTA2 gene sitting right here in the middle. If you take people that don't have any features of Marfan syndrome, this is the most commonly altered gene. And so it is more commonly changed to cause disease than many of the other genes on this list. So, and this is just to illustrate some of the families, and something that very surprisingly came out of our families with ACTA2 mutations. And this information is very important for people that have ACTA2 mutations to understand. So I'm going to spend a few minutes talking about this. The other problems with the arteries that we can see in patients with ACTA2 are alterations. So here's the family we actually use to map and identify ACTA2. And in this family, everybody with an orange circle around their symbol has this ACTA2. They have this variant called arginine 149C. And everybody with the black has aortic aneurysms or has presented with a dissection. And this was the age of onset of the disease. So here in this family, you can see that this young boy presented with an aortic dissection at 13 years of age, where this individual up here presented at 67. So we can have this wide range of age of onset, even within one family. And then you can also see here, there's some men over here that have the variant, and they must be in there, based on where they are in the pedigree, must be around, 40 to 60 years of age, and they do not have disease, whereas other younger people have established disease. And once again, that's that decreased penetrance. And in this case, it's occurring in men, but in most families, it occurs primarily in women. But the penetrance of ACTA2 in this family is only 50%. In other words, if you get the defective gene, you only have a 50% chance of getting thoracic aortic disease with this particular variant. And actually, this guy, when we were recruiting the family, he got up and said, we have a lot of people that have early onset heart attacks in our family, and they don't have any problems with their cholesterol, and they don't smoke. And could it be the same gene? And at first I said no, But after we found the gene, we went back and looked more carefully. And as it turned out, the ACTA2 mutations were causing both thoracic aortic aneurysms and dissections, and early onset atherosclerosis, also called coronary artery disease, because the atherosclerosis is blocking those blood vessels for the heart, called the coronary arteries. And as you can see, these people have no risk factors for coronary artery disease. But despite that, they're presenting with heart attacks starting at the age of 33, 43, and so on, very young age of onset of this coronary artery disease. And we've been working hard to understand this disease in ACTA2 patients. And based on work that Mauro Borio is doing in my group, we now know that the atherosclerosis goes beyond the coronary artery disease. It can involve the carotid arteries outside of the brain. It can involve the arteries in the leg, and it can even involve the aorta itself. So it can go way beyond just the coronary artery disease and arteries, and affect other arteries in the body. And we've been working hard on trying to understand, you alter just one gene out of the approximately 20,000 genes that we have in our genome, and you end up with two different vascular diseases. And one's an enlargement of an artery, and coronary artery disease or atherosclerosis is where that atherosclerotic plaque actually blocks the artery so that blood cannot flow through it, and that's the cause of the heart attacks. And so it's like two opposite sort of changes in the arteries. And we're, like I said, I'll present some, where we are with those studies, and more importantly, what we're recommending with people that have ACTA2 mutations that predisposed also to coronary artery disease. But it is very important to say it's just a subset of mutations that cause coronary artery disease. All the variants that we have that are pathogenic variants in ACTA2 all cause thoracic aortic aneurysms that can lead to aortic dissections. It's only a few mutations or variants that also predispose to coronary artery disease. And there's other variants that cause a completely different problem with the arteries, and that's a disease called moyamoya. So here's a family that has a different change, just called arginine 258 to cysteine, or R258C. In this case, they have the aortic disease, but they do not have coronary artery disease, but instead they have blockage of the big arteries that go into the brain. And here's an image of this young girl who had a blockage at the age of 16. Both of these arteries, here's the carotid artery coming up. It's wide open. In fact, it's even a little bit enlarged. But you can see over here, there's no blood going through on this side, and it's highly stenosed. It goes down to essentially nothing over here, just a very small trickle going through over here. And that occurs right where the carotid arteries actually go into the brain, that you end up with those blocks on both of those internal carotid arteries as opposed to the external out here. And that's a disease called moyamoya disease. And because the arteries are being blocked, it can lead to strokes. And the strokes with this particular variant can start very young. This young girl had this imaging done because she had the stroke at the age of 16. This young boy had his first stroke at the age of 5 and died of a second stroke at the age of 8. So this can be started very young. And this 258 variant, arginine 258 to cysteine, is one variant that causes disease. And another variant is ACTA2 arginine 179 to any other change that also causes disease starting as young as 16 months of age. So these strokes can start at a very young age, and the children with this particular variant. In this case, the variant shows up new in these children. That means mom and dad have 2 normal chromosomes, and suddenly the child is born with this alteration. And that's not, it's just by chance. It's nothing that the parents do. It just means when the cells were going to make the egg and sperm that donate half the genetic material, that in the egg or sperm, when they were making the DNA, there was a mistake made. And in this case, the mistake was in the ACTA2 gene and caused this variant. And it ends up causing this condition called smooth muscle dysfunction syndrome. So these kids have very early onset thoracic aortic disease starting in childhood, and they have severe moya disease starting very young, but they also have problems with every single organ in their body that's dependent on smooth muscle cells. And these are the muscle cells that contract without us even thinking about it. So it's the muscles in our gut that push the food through our gut. It's the muscles in our bladder that allows our bladder to contract down so we get all the urine out of our bladder. It's the smooth muscle cells in the uterus that pushes the baby out at the end of the pregnancy and so on. So there's a lot of smooth muscle organs, and these children have problems with all of them. So it's a very complicated condition and a very severe condition. So we have all these ACTA2 mutations or variants that cause thoracic aortic disease. We have a subset that causes coronary artery disease. And then these 2 variants that cause moya disease in addition to the thoracic aortic disease. And we wanted to ask just first, what's the age and the onset? If we look at everybody with an ACTA2 mutation, when do they have their first aortic event? What age do they have their first aortic event? And here's a graph that looks at and we define aortic event as surgical repair of an aneurysm or presentation with a dissection. And here's the age of onset of one of those events based on each individual gene. And here in green is the ACTA2 gene. And so I can tell you right now that most of these events down here that start in childhood are in the smooth muscle dysfunction syndrome patients. But you can see there's a wide spread of age of onset. If we look at 50% of the patients will have an event by their mid to late 40s. Okay, and these are other genes. These are those Loeys-Dietz syndrome genes. And then this is a gene called PRKG1. It actually has the earliest onset of any disease gene in terms of disease. And this one has the latest onset. So ACTA2 falls right in between. And this is broken down based on the specific variants that we see recurrently in the gene. And here is that arginine 179, and this is the age of onset of aortic event. So this just once again shows you that these kids with the smooth muscle dysfunction start having aortic events in childhood. So we have to watch them very carefully. But there are many, many variants that have much later onset, even some that have onsets way into their 50s and 60s. But on average, if you look at the other variants here in green, you can see most of the variants are still following and having aortic events around the mid 40s to early 50s, in that range. Okay, and then are there gender differences between men and women? These are the 2 of the Loeys-Dietz syndrome genes, but here's ACTA2 with men in the dark line and women in the slash line. And you can see men have a slightly earlier onset of risk here about a little bit into their early 40s, and women around 50. Okay, so what do we do about this risk? So if you have an ACTA2 mutations, you have to be imaged routinely. If you have a child with SMDS, they have to be very aggressively imaged, even probably more than once a year. But for most of the mutations or variants, we recommend once a year. We want people to be on a medication that slows the rate of growth, and we recommend primarily beta adrenergic blocking agents like a tenolol, metoprolol, and so on. And then we're recommending aneurysm repair, not at 5 to 5.5 centimeters, but much more aggressive than this. This is for the general population, but for ACTA2, we're recommending at 4.5 centimeters, so a little bit earlier than the general condition. The most important thing you can do as a patient with an ACTA2 mutation is manage your blood pressure. We want that upper number to be under 120, preferably running around 110, okay? And the lower you can get it, the better. So those aneurysms and those dissections occur based on two things. One is how strong the aortic wall is, and the ACTA2 variants cause the aortic wall to be weaker. But the other big factor is how much pressure there is on that wall. And all that pressure is due to blood pressure. So we want you to keep that blood pressure as low as possible and avoid isometric exercises. And I think there's already been sessions talking in detail about what exercises to avoid and which actually we recommend. And for ACTA2 patients, we recommend aerobic exercises, and that's things like walking, running, bike riding, swimming, but we don't want you training for a marathon and or trying to do very, very long bike rides. And then if you have one of the variants that leads to coronary artery disease, and we're just working through the data where we have an assay now where we can say with a high degree of confidence which variants cause atherosclerosis and which ones don't. And this is the pathway, and I'm not going to go through it, but it says that statins, that those drugs that are used to lower cholesterol, will work to prevent the coronary artery disease in patients with ACTA2, even if they have completely normal cholesterol. So whether your cholesterol is high or not, you absolutely need to be on a statin if you have one of the variants that causes coronary artery disease, like that arginine 149C. And then we've been working to really understand why the arteries in the vein get closed off in patients with the arginine 179 and the arginine 258. And we know that what happens is that when they go to make smooth muscle cells, they end up with an immature smooth muscle cells. And we actually have a drug that really pushes maturity of those smooth muscle cells in when the ACTA2 change is there. And we've even made an animal model, and using this drug, we can prevent the strokes in that animal model. So we are starting a clinical trial. In fact, all the paperwork has gone into our institutional review board that reviews anything we do with patients to make sure that we're doing it in an ethical and a rigorous way. And then we have to have approval for the FDA to use the drug that we want to use in the clinical trials. So the paperwork has gone to the FDA, and I'm very grateful. Dr. David Murdoch, who's given one of these seminars, he just joined our research program, and he's been working on all that paperwork and getting all everything ready to get the first phase of the clinical trial going. So got lots of people to thank, including Ellen Regalado, Bella Marin's on the call too. She's our genetic research nurse. And then Mara is a wonderful research assistant that's been collecting all the atherosclerosis data. She has sent out a survey to all of the ACTA2 patients in our research programs. Please fill that survey out. I don't think it takes much time, and you get a nice Amazon gift card. So please, please fill it out. The better response we get, the better the data is and more confident we can be in terms of which variants cause coronary, atherosclerosis and which don't. And then also, how far does that atherosclerosis go, in terms of the arteries involved? And I just want to mention that Abby has been, and Anita and Kavita and Callie have been working on the other vascular diseases. And it's those people in my laboratory that have done absolutely amazing work to really understand those conditions so we can treat them better. And the data is so exciting, but like I said, I'd put you all to sleep if I went through the molecular biology. So, and I really want to thank GADA for supporting the Montalcino Aortic Consortium. Once we find the genes, we collect the clinical data so we can manage the people correctly, including that atherosclerosis and Moyamoya disease. So GADA really contributes to that. And then we're very grateful to the John Ritter Foundation because they've been funding our studies to find all these genes for many, many years. And then also the Marfan Foundation has helped us with understanding severe early onset Marfan syndrome, and then the American Heart and NHLBI, and then some foundations that are based on patients and really have gotten a lot of funding from these foundations also. Very grateful for that. Okay, I'm ready to answer questions now. So let me go ahead and stop sharing.
Well, I think you'd be surprised. There's a bunch of people in the chat saying they want to hear the detailed scientific data for some time.
I can do that. I would actually absolutely love to go through that because the story for both conditions, I think the story is going to tell us a lot about those diseases in general. Like the treatment we're finding for Moyamoya disease, we think will apply to all childhood onset Moyamoya disease. And for years, we've known that statins work in people that don't have high cholesterol, and nobody really understood why they work so well. And actually what we figured out with the ACTA2 variant really explains what might be going on. And the story is just fascinating.
It's incredible. Well, you will have to come back then for more molecular biology.
Okay, they're going to have to put their science hats on. Okay.
You have a ton of questions, and I will start, but then I'll just go back and forth with Christiane if you'd like. One I wanted to bring up because it came up in the chat as you were showing your slides there, and someone questioned about medication, beta blockers. Should you go on this based on your age, if you have an aneurysm, if you've had surgery, like what the decision to go on a medication for blood pressure, what should that be based on, or just having an ACTA2 variant at all, period?
Okay. For ACTA2 variants, we feel very strongly that people should start the medication even if they don't have enlargement of their aorta. Now, I talked about what are called type A dissections, and they start in the first part of the aorta, but people with ACTA2s variants can also present with type B that go down the descending aorta. They tend not to be life-threatening when they happen suddenly, but it's not unusual. People have to have surgical repair of those and so on. So we want to prevent those also. And we know in ACTA2 patients that, number one, up to 30% of the patients will present with a type B dissection. So it is a major factor. They will not have enlargement of the aorta, so we can't predict it. And it tends to occur young. So like in that ARGENE149C family where I showed that 14-year-old with the dissection, that was the type B dissection. So it's not unusual that people come in. In fact, our data say that type B dissections occur before type A dissections with ACTA2. So we want to start the beta blockers in childhood. And I would say definitely by 12 years of age. You want to push it up until they have symptoms. And then once again, limit the activity of those children. And so no heavy weightlifting or any of those isometric type exercises. And we don't want kids to get like big blows to their chest. So we don't want them playing football or any sort of contact sports.
And how about losartan? Someone just asked here, is that a good alternative to beta blockers? I know there's
It is an alternative if somebody doesn't tolerate the beta blockers. So we have a lot more data that beta blockers block dissections. With losartan, we only have data that it blocks aneurysm growth, but we don't have good data that it blocks dissections. So we really prefer patients with ACTA2 be on a beta blocker. Now, beta blockers don't completely prevent dissections, but there's data in animal models and some humans conditions where it can block dissections. But we are really looking at, we just launched a big international study with funding from a foundation called the Leduc Foundation to really understand what converts an aneurysm to a dissection and what causes those type B dissections with no enlargement of the aorta. What's going on in the wall to trigger those dissections so we can have drugs that in particular target dissections. And if we did that, we would recommend, if we had better drugs, we'd say every single patient with an ACTA2 needs, by the time they're young, early teens, needs to be on those to prevent the type B dissections, but also decrease the risk for a type A. And if they have that 179, we recommend starting it even younger.
Okay.
But we don't have, so give us 5 years, because now that we've got the cerebrovascular disease understood and the atherosclerosis, my focus now is really to understand those molecular triggers of dissection. And I'm, the Leduc Foundation, we just received the money, but it was 7.5 million to figure this out. So it goes, we have collaborators in Europe and in the US. So we're putting all these great minds together to try to figure this out. I think it's going to be very productive.
Yeah, I think that's amazing, Dr. Milewicz. A question around the genetics. So we've got some questions here that people are interested in knowing what kind of genetic test should they do if they think they have ACTA2. Is it look for one gene or more than one gene? Or if you have an ACTA2 with one variant, could you have other genes that are also involved? And, what kind of genetic testing would give that kind of information?
So right now, anybody that we're recommending anybody who has aortic disease that has a family history and other people affected in the family, or has the onset under the age of 60, or has those features of Marfan syndrome or Loeys-Dietz, that they undergo genetic testing. And we test, the testing companies test all those genes on that list at once. And that's right now the most cost-effective way to do it. The testing costs much less than an echo and much, much less than a CT or MRI. So it's not, more and more healthcare systems and insurance covers the testing. Used to be we had to get approval for every single patient. Now it's very rare. So those are what are in the treatment guidelines right now, the updated ones that I participated in that were just published in the fall of 2022. Yeah. And then they test all the genes. If you come back with a variant, it can be a pathogenic or likely pathogenic variant, and that means it's disease causing. So we can use it to identify other family members at risk, and then make, like I said, through data gathered through the MAC consortium, we can start predicting what's going to happen and make recommendations in terms of the drugs, the imaging, the other vascular diseases, and so on. And if it comes back as having a VUS, a variant of unknown significance, or benign, that means it's negative. And in that case, we just image all the family members to look for those aneurysms And then we follow people that have aneurysms. And we would love, if you're one of those families, we'd love you in our study because we have to find the rest of the genes. We have another couple that we're working on, and then I'm sorry, more like another 5 more genes we're working on. But like I said, we have a large number of genes, and we really want to be able to take advantage of machine learning and artificial intelligence to do this faster. So
if they do come up positive for more than one gene, ACTA2 and another, would they have both connective tissue, a connective tissue disorder?
it's extremely rare that people would have pathogenic variants in 2 genes.
Right.
You never say never in medicine, so I know there are examples out there, and in those cases, the disease tends to be very early onset in childhood and more severe than either one of the parents had. Because if the child has both variants, chances are, one parent has one variant and the other parent has. And it's also, we found kids that have parents, like both parents have ACTA2 mutations, and they end up getting both ACTA2 mutations and having dissections in childhood. So.
We had multiple people write in ahead of time, and then they're also asking the chat again. So I will prioritize this question. It's about pulmonary hypertension, and I believe both
good question.
Who sent in ahead of time have the variant R258H. But I don't know if that's the case for people who are writing in the chat now, which is I'll add that in the roundtable. I asked a question: how many people know what variant or mutation you have? And I'll say the majority of people, I think it was about 70%, said that they knew or could easily, look it up.
Yeah.
So just to share how important it is, your discussion today really has brought home how important it is to understand that and make sure your clinicians understand what that particular change is as well. But they just said, can you talk about pulmonary hypertension? So
pulmonary hypertension definitely occurs in the children with smooth muscle dysfunction syndrome, that arginine 179. And so the only other mutation that causes Moy disease is 258. So I'm not surprised that patients with 258 can have pulmonary hypertension. And we would love to get that information into the Multitudo Aortic Consortium data so we can publish that and make people aware that there are these 2 variants that cause not only Moy disease, but pulmonary hypertension. Now, the drug that we're talking for proposing to use for the blockage of the arteries in the brain may also improve the pulmonary hypertension. Pulmonary hypertension means that the arteries to the lungs are becoming blocked, and that leads to the blood pressure going up because it's having trouble pushing the blood through the arteries going to the lung. And so it's the same kind of changes in the artery that we see in Moy disease. And so we think the drug will affect both. And as we start this trial, we want to collect not only what's going on in the brain and the aorta in these kids, but also in the lungs. And also there's reasons to think it would improve the gut and the bladder too, for different reasons that once again, have to go into the molecular biology to explain. But we think that the drug will help the pulmonary hypertension. So we're starting this clinical trial with the 179 patients, but I think we will be extending it to the 258 patients, also the arginine 258 patients also.
And someone has followed up by asking what the name of the drug is, and
we can't give it out because it is pretty. It is something. So it is a drug that's used commonly and very available. And the rule is, in terms, if I'm doing a clinical trial, I have to get all the approvals. The FDA has to say it's okay. But you can go to your doctor and say, I want to be put on this drug. And then if we gave the name out, then everybody would go to their doctors and get on the drug. And we wouldn't have a chance to really most rapidly and efficiently figure out if it's making a difference or not.
So please stay tuned for
Stay
more.
tuned. Yeah, we're working as fast as we can. I know everybody's frustrated because it's going slower, but even like going to the FDA, this could take up to 6 months for them to make a decision. We're hoping it doesn't, because it's not at all a dangerous treatment at all. I mean, there should be no side effects of this treatment.
Yeah, another question from a family who has a son who's 37 years old and recently had a second open heart surgery to repair dissections. Since his first dissection, he has had several what he calls a curtain closing on his right eye, where he loses vision up to 30 minutes or so. So the patient,
It's really worrisome that
had a
he's having
TIA.
TIA or a transient ischemic attack. Did they know the variant?
I'm not sure if they know the variant. I don't think so.
Okay, I think that he needs a cerebrovascular, the brains in his arteries looked at, especially if he has the 179 or the 258
I
variant.
don't think it was the 179 even.
I don't think so either, but the 258 could be.
I know I can see that the person who asked that question, and I know they are involved in your research, Diana. So or hopefully they can.
Yeah, I need to know. It's yeah, give us a call so we can get an update.
Yeah. Okay. So this is a good question that I think is perhaps just a good reminder. So someone asked about basically how confident are you about that these mutations cause this disease? So it sounds like they're in a family with R149 mutation, but they do not have it. Can they be assured that they will not have a dissection? They do not need to.
Their risk goes down to the general population risk, and the risk of a dissection it's pretty rare. And let's see, there's 10,000 dissections a year in the US or something like that. So it's out there, but it's not that common. And so
be reassured, person in the chat asking this question. We are confident.
Right, and I think going back to the earlier one, so what kind of imaging is recommended for ACTA2 patients? MRI versus a CT? Get the brain involved too in this?
Well, so first of all, starting with aortic imaging, we recommend an echo, but they have to be able to see that very first part of the aorta. That with an echo, you can see the very first part really well. That's called the aortic root, but they also have to be able to see up the aorta. And if they can't do that, then they have to go to a CT. And we really would prefer instead MRI, because you know, the ACTA2 patients are going to have a lot of imaging of their aorta over the years, and we want to limit that radiation. And certainly at the time that a person's diagnosed, they should have the echo, but also that MRI, and really just to make sure that everything's okay with the entire aorta. It's those type B dissections, like I said, they tend not to be deadly. And sometimes people have them and they may have some back pain, but not realize that they actually dissected their descending aorta. So it's not common, but sometimes with those initial imaging, we'll find an undiagnosed dissection of the descending aorta. Right. And we do have to watch them because they do grow into aneurysms and do need to be repaired. The good news is that there's a possibility for in some cases to do that without having to do open surgery, but instead putting in those stent grafts into the aorta to repair them may work in some cases.
Right. And also back to the previous one, how the family wants to know how are TIAs related to dissections, if at all they're related to dissection. What are
so the dissection, there's two ways it can be related. One is that they have an ACTA2 mutation that causes both the moya-moya disease and the dissection. And in that case, their arteries would be narrowed or completely blocked. And there's things even without our clinical trial, there's things that can be done to prevent those TIAs in that case. So the dissection, when it occurs, it tears the aorta apart and can disrupt the arteries, the carotid arteries that go up into the brain, and either alter the blood flow to the brain, or if there's like a little dissection that goes up into the carotid artery, they can form clots there and start throwing up clots and causing strokes that way. So they just really, if they're having this feeling that the lights are turning off like that, that's pretty classic for a TIA, and they really need to go see a doctor immediately.
Right.
Because they figure out, is it a clot? Because then we put them on anticoagulants. Is it they have, moya disease? Then there's other treatments for it. So, yeah, need to get that figured out.
We had a follow-up question about when you're talking about statins, and this question specifically asked about for a young woman, should they go, if they don't have any symptoms, should they go on a statin if they have an ACTA2 mutation? But in general, we've had some chatter about should everyone with ACTA2 just go on a statin just to be safe? Is it
we'll be coming out with the data soon. I can give you the numbers right now. Or if Mara, is she a panelist? Is Mara a panelist?
She's not a panelist, but she's in the chat.
Okay, she'll put these in the chat. It's arginine 39, arginine 149, arginine 212, arginine 198, and G275. So it's all arginines. But once again, get those surveys in so we can get this figured, we want to put the clinical data together with our assay that tells us if this pathway that leads to early onset coronary artery disease is increased with a mutation, together, and make sure they match up before we publish this data. And that's Mara's work, and she's doing a great job.
And a lot of people have been asking if they can participate. Yes, they're the best. A lot of people have been asking if they can participate in research if they don't live in the United States, and the answer is yes. So please do not let that be a barrier for you.
Yeah, that we need, it is very helpful for us if you speak English or Spanish, because our institutional review board requires us to consent you in your native language. In the language that you're familiar with. So if you're not familiar with English and Spanish, it's very difficult for us because we have to find somebody who can consent you. They have to agree to help us. We have to put them on our protocols. We have to translate this consents into that language. So it's a lot of work. But English and Spanish,
English, and you live in New Zealand or Australia or anywhere in the world, that's great. Yeah. And it can all be done virtually. So I know that Maura and Bella are in the chat giving info.
Yeah, and I assume they're putting in the email addresses if people are interested. And so we have some standard email addresses, and people will follow up with you if you send those emails.
Yeah, absolutely. Can we still get you for a few more minutes, Dr. Milewicz, or do you need to go?
A few, yeah, I'm fine. It's
okay, there's a lot more questions. So people are like so hungry for this information, I think, because they're used to not, it's usually not ACTA2 specific. It's either, a wider net or something. So I think they're very hungry for your expertise.
Yeah, so I'd love to do one on the coronary artery disease and explain why that works and how we're figuring out which variants cause atherosclerosis and which don't. And then love to talk, once we get the trial going, love to talk about that and all the details and what the expectations with that'll be and what we hope to add on to improve this treatment going forward, because we have a lot of different the information is really pointing to multiple different pathways that we can go to prevent the blockage of the arteries and hopefully improve, like I said, the gut function and so on. Very promising. And I know there's a group in Boston that's working on going in and doing gene editing, CRISPR-Cas, But I encourage that to be done, because I think, that would be the ultimate goal, to go in and actually fix that mutation, not only for the smooth muscle dysfunction, but for everybody. But I think we're still, 10, 20 years away from that. And so in the meantime, I think we need the better therapies now and not wait.
Yeah, got it.
Right. So we had some questions about kids. People asked about at what age is it appropriate to test kids who have an ACTA2 gene, and what is the recommended screening for children?
Okay, so children, like I said, we can see those type B dissections starting as young as 13. So I say by 10 or 11, go ahead and get them checked. Based on having the ACTA2 gene, they cannot be discriminated in terms of medical insurance, but they can be discriminated against in terms of life and other insurance. So think about, before the testing, think about whether you want to go ahead and get life insurance, long-term care insurance, all those other things. But I would go ahead and test. And then once again, if they do have the ACTA2 mutation, they need to be seen by a pediatric cardiologist, imaged as baseline images. Chances are everything will be fine. And then started on a medication to prevent those type B dissections.
Right. So for kids as well, would you recommend the echo is sufficient, and then move on to
Typically in a child, you can see the root and the first part of the aorta. And in a child, I'd be less, we're writing the children's guideline now, and I think they will be recommending a baseline CT or MRI with a heavy emphasis on the MRI for children.
Right.
But a 12-year-old should have a normal aorta, but I think that the pediatric cardiologists really like to know that.
Right. Right.
And once again, for the 179 and even, much more aggressive for that.
We've been talking a lot of the specific mutations in this talk today, and we had a message here, which is so important. And can you just briefly talk about what these letters and numbers mean? Because I think sometimes, whether it's abbreviated with 1 letter or 3 letters, people might get confused. Are these all the same? How do you read your mutation, and how do you know what you truly have? Because I think we speak to these letters and numbers, and
starting with a little bit of genetics 101, but then I took it out because it would have made my talk like 40 minutes long or 45 minutes long. So I took out the genetics 101 and focused on the clinical disease. So the genes, the DNA sits in we're made up of millions of cells, and in every cell there's a command center called the nucleus, and that DNA sits in that nucleus, and the genes are part of that DNA, and they tell the cell how to make the proteins, and the proteins are what do the work. And ACTA2 makes a very interesting protein that allows force to be generate or contraction in the tissue, called the thin filaments in smooth muscle cells. And so the proteins, the genes are made up of just 4 base pairs, and the mutation will be reported out as both the base pair change, but then when it goes to the gene makes the protein, that we have 20 amino acids that make all our proteins, and they all have names like arginine, cysteine, and so on. And those 20 names, can be shortened to 1 letter or 3 letters. So arginine can be an R or an ARG. Cysteine can be a C or a CYS. So it just says you're making that protein, but there's 1 amino acid out of I think it's about 300 amino acids that make up the actin protein. It's just one amino acid that's changed in there. And that's what's causing all these problems. Pretty amazing. That's what I love about genetics is one base pair change out of 3 billion in every single nucleus that we have there of nucleotides, and then just one amino acid change out of 300 in that specific protein.
So if you don't know what your mutation is, I would highly advise getting a copy of your report. You can contact your genetic counselor or whoever, order that testing.
Contact us and we'll
or if you're in the research, yeah, we can.
And we're actually updating all our letters in terms of our recommendations with the different mutations. Now, I wrote up these recommendations for the treatment guidelines that were published in the fall, and they came back to me and said, you know, these are so detailed that we can't put them in because it takes up too much of the treatment guidelines text. So we're coming up with our own separate guidelines for not only ACTA2, but the other genes that we study in GADA and for EPN1. So look for those. In the meantime, our updated letters, and we probably need to make those recommendations on our website and on GADA and on JRF. In terms of what to do based on the specific mutations in these genes and get those up on the website. But we will have those things in our reports out with the different variants. I go back and forth. So in the genetic community about 10 years ago, it was decided that we would no longer call them mutations, but instead call them pathogenic variants, because mutation has a very negative connotation.
So I asked this at our last roundtable. I said, which do you prefer? Because there's a debate online, you know, different patient communities, I think, have different feelings about it. And, you know, the most common answer was that they didn't really care. They still care, you know, so it's can be confusing, I think, but
then it leaves me saying mutation, also variant, you know, going back and
yeah, it can be even more. Yeah, but this, if anything else, I think your talk today has really illustrated how important it is to know that.
Oh, absolutely, definitely know and the variant can make a lot of difference too.
That's right. In fact, I have a question here from someone in Canada who says her sister died of an aortic dissection, and she herself has had an aortic dissection, but no gene identified. And so, in this particular case, what is the best course of follow-up, medical care follow-up for these?
Well, we want her in our research program, so go ahead and email us. Bella put the email back out there again in the chat, and we can prevent dissections and other, at least those deadly type A dissections, by imaging all the first degree relatives for aneurysms. And let's say you image your mother and she ends up having an aneurysm, then you would have to image your aunts and uncles on that side and her parents if your grandparents are still alive. Right. So we do the imaging of all the first degree relatives, so that's parents, siblings, and children. And then if anybody shows up positive, extend the imaging. But almost everybody who has a dissection has enlargement of the aorta before they dissect, some degree. So we can pick up who's at risk and who's not by just doing the imaging. Right. And that is a big part of the treatment guidelines, because that's still the majority of families. We cannot find the variant causing disease. Chris Ann keeps on going in and out.
You're
gonna have to a broadband connection.
Yeah, definitely. Are congenital heart defects more common in ACTA2 than in regular?
The only congenital heart defect that is increased is a patent ductus arteriosus. And once again, it seems to be mostly in the smooth muscle dysfunction and with the arginine 258 variants. Those two variants that seem to fall a little bit more on the more serious end of the spectrum. And they can be there with some of the other genes like TGFBR2 and MYH11. It's some of the variants there, and those genes cause patent ductus arteriosus. We think that there may be a slight increase in a bicuspid aortic valve in the ACTA2 patients. And that's the valve between the heart and the aorta. And usually it looks like a Mercedes-Benz sign. It has 3 different leaflets. And a bicuspid valve means that it has, instead of having 3, it just has 2. But we still don't, with our original data in the population, it's about 1 to 2%. And original data in ACTA2, it was 6. But we need to go back and verify that again. Okay. And somebody just asked if it matters if it goes to, if the 258 is changed to a cysteine or a histidine. For arginine 179 and 258, we don't think it makes a difference right now based on our clinical data. But for the arginine 149, it may actually make a difference. Some of our data says it does make a difference in that case. So stay tuned. But definitely the 149C and the 149H cause atherosclerosis, a predisposition to atherosclerosis. So in those families, still the majority of people get aortic disease, but it's up to like 30% of those family members will have atherosclerosis.
And I think we did have someone write in that they had both a dissection and recently had a heart attack. So
yeah, it seems to go one way or the other, but there are people that have both. And once again, love to have you in the research. So start understanding that. And why one person tends to go one way and the other way is really an interesting research question.
So everyone with those, the R149 and the list that Maura typed in there, should they ask for screening for coronary artery disease from their cardiologist, like a stress?
Well, I think they need to start statins at a relatively young age. And I would say by the time they're adults, 20.
Okay.
We know that even people with the 149C and some of these other variants that they have had, unfortunately, if they have been imaged or died of and had an autopsy, that they already have coronary artery disease. So we want to get it started early because it's a chronic disease and there's the progression, just like there is progression of an aneurysm to a dissection. We want to block it as early as possible. And statins mostly don't have side effects. There's people that have problems with their muscles with statins. And so we actually just submitted a grant yesterday to understand that, to try to figure out if there's other places we can block similar to statins, but won't have the side effects of statins. So we're working on that too.
That's great. Another question that is like 2 mutations. So someone asked us that he was recently diagnosed with hereditary alpha tryptasemia and has an ACTA2 mutation. Is there any sort of link between the two?
Well, there's a worry because the alpha trypsin deficiency syndrome, I think that it can cause problems with degrading elastin fibers, and ACTA2 patients also, what the disease process, especially in the aorta, can involve disruption of the elastin fibers. So you should really talk to his physician about that, because there are ways to treat the alpha-1 antitrypsin deficiency.
Right.
I think we probably need to let you go at some point here.
Yeah, I actually have another genetic lecture to give in an hour and a half.
Yes. But I couldn't let this one go by because I know you have a thought on it. Someone said, is ACTA2 a connective tissue disorder?
That's a great question. ACTA2 encodes a gene that makes a protein that remains inside the cell. So based on that, it doesn't have the gene itself does not have anything to do with the connective tissues. The connective tissue is outside the cells, and it helps provide a matrix for the cell to hold on to and to be a part of. And but in this case, the protein remains inside the cell. But we have data that, and there's lots of data already in the literature, that especially for muscle cells, how well they contract helps the matrix mature. So there could be a secondary defect in the matrix, because we know that those the ACTA2 mutations disrupt the ability of the smooth muscle cells to actually generate the force that they should be generating when they contract. So there may be a secondary defect in the matrix, but I would not put this under a connective tissue. And even like TGF-beta mutations in low estates are considered connective tissue. But once again, those are all encode proteins within the smooth muscle cell that are secondarily affecting the matrix. So it gets very complicated. But I would like to move away from the idea that all thoracic aortic diseases are due to connective tissue disorders. That's not the case. Connective tissue proteins or whatever.
Yeah.
Okay.
Again, the terminology.
Yeah. Good. Good.
Well, I think we should probably leave it there, because we've taken more than we asked for from you. But
yes,
really,
and I'm more than happy to come back. And if you have the list of questions in the chat, we will try to get to them. And between Maura and Belle and I, we may be able to come back and answer many of those and get them posted on the website. Okay.
Great.
Good.
Yeah, that'd be great. And if folks really are interested in the molecular biology of it, in April, actually, the John Ritter Foundation is doing a webinar. Dr. Portler from Dr. Milewicz's lab is going to be speaking at it, sharing some of her research that will be.
Not even know this.
Yes, as well as someone from a researcher, basic science researcher from Stanford and WashU and St. Louis. So we have 3 different basic science researchers who are going to be talking about how their work relates to thoracic aortic dissection and aneurysms, and it will be for a layperson audience, so no PhD in biology required to attend, but
would help.
But some of the speakers do specifically work on ACTA2, so it will be really exciting to hear that. So if you said you were interested, you show up so that make sure we have.
Ellie doesn't feel bad.
So that they feel the love as well.
Yes, yeah, and the work they do is so important, so important. Okay, well, thank you for the invitation. I hope that provided information for everybody.
Yes, well, there's lots of thank yous in the chat I can see. So thank you for being here, and thanks to GADA, of course, for co-hosting this with us. But
thank you, Dr. Milewicz, and thank you, Ellen. And like Dr. Milewicz already said, if your questions are in the chat, we'll get to them if we didn't already address them in this session. And if you feel like there's any more information you need on GADA or GRF events, please connect with us through our website or our email or social media. You can reach Dr. Milewicz through us if you want to. But yes, thank you so much, Dr. Milewicz. Thank you, Ellen. And thanks to everyone who's made this so effective, such an effective session, just from your questions and your comments for ACTA2.
it was wonderful.
Okay, thanks, Chrisanne. Thanks, Ellen.
Yeah, thank you.
Thank you.
Bye.
Thanks, everyone.
Bye.
Bye-bye.